I made the mistake of coming this morning at 8 o'clock, and it was, I will say, a very humbling morning for me for a number of fronts. As I was sitting in the audience and watching speakers, it occurred to me that this is the first time I've ever been face-to-face with Ed Bentz and Bill Haight since we were all in training in New Haven a number of years ago. And Ed was nice enough to point out to me that that was 32 years ago, which is very humbling. And then the second thing that humbled me was that I felt like I had the same knowledge base today that I had 32 years ago after listening to the basic science this morning. The fields exploded in a way that, to me, there was a lot of French being spoken. So I think it's relevant because it is going to be a bit of an issue. And the third thing I'm humbled by is the number of things that Mark McClellan said I would speak about today, and I'm not going to. So you have seen this slide in this very room. Some of you saw it last Friday at one of the ASCO quality meetings, and I will continue to use it because nobody is paying any attention to it, and until you do, I will keep on saying this. This is a graph that tracks just two trends. The first trend is the average U.S. household income. It's projected, of course, from about 2012 on forward, but these are real numbers. And the second line, the one with the dots in it, is the amount of money it takes to pay for your out-of-pocket expenses and a health care premium for an average U.S. family. Okay? So when you look at those curves, there's a couple of important events happening. One here is in the year 2016, which is about 3 years away. And at that point in time, it's going to take 50% of the average U.S. household income to pay for your out-of-pocket expenses and a health care insurance premium. My wife was just totaling up the year. We've had a set of orthopedic disasters in my family. We will spend $23,000 this year for health care premiums and out-of-pocket expenses. I work for a very generous company. I'm well insured, and that is just about half of the average U.S. household income. Okay? Completely, unequivocally unsustainable. And this is exactly the kind of curve that bankers were looking at in the mortgage crisis and shaking their head and saying it can't possibly be. And almost every healthcare audience I'm in front of says exactly the same thing. This can't possibly be. And you're right, it can't. But each and every one of us will feel this. Each and every one of us will have less money and fewer resources to care for more patients. And when Mark McClellan just a few minutes ago said we're thinking about an SGR that's flat for the next decade, I was surprised a number of people didn't faint. And this is why. There just isn't any money in the system. So as you think about that, contrast that with this morning when we saw an explosion of new ideas and the potential to do some really good, exciting things within cancer therapy. And where is it going to be funded? Some people, in fact, Lynn actually already talked about coverage with evidence development, and Lynn, there's no money for that. So I have to disagree with that approach. And that's where we're going to have to think about how do we become more efficient both in the research arena and in the delivery of care. So there are a couple of things that I think we're going to have to do environmentally that we're going to have to create. One of those is we have to rapidly sever the relationship between an oncologist's incomes and the drugs they select. That has to go away. We need to pay oncologists for taking care of patients, and they should not have any influence in that payment based on which drug they selected unless it actually is tied to outcome. Then I'd be more than willing to look at that. And then the second issue that seems to be emerging, there's been such a good job of promoting the genomics world that I'm seeing, and in fact being bombarded daily with requests for therapies that I call the unproven gene, the actionable gene in an unproven cancer. We've run the genome, we've found an actionable gene. I want to use this drug. No, it's never been used before in this cancer, but we've got a picture in the New England Journal of one patient who did exceedingly well, so I want to try it now on a lot of patients. And that's a long ways from science. I think the other contrast I drew from this morning is that you noticed I said actionable gene in an unproven cancer. We're looking at that in the clinics today very simplistically. One gene in one cancer. Yet you heard this morning that it's really about complex molecular systems and that we really need to understand the systems biology of those genes to do this well. So this very simplistic approach, which is being done now in the practice routinely, isn't going to work. And I think we heard that loudly and clearly this morning. So I would ask us to think about several things if we want to push forward the new testing, the new technologies. And I should have named this slide collaboration. We've heard that request from almost every speaker in one form or another today. And one way we can collaborate is to simply work together to develop the ends we need to create evidence. But that means that academic centers and community practices will need to be contributing the information and the patients into a common pot where we can access that. Now, from a technology standpoint, somebody, I think it was TGen, said we're going to network that data. That's fine. We don't need one big registry, as I may have said here. But we do need the ability to access that data so that we can learn and learn exceedingly quickly, a la Lynn Etheridge. The second thing we need to do is provide pharma an environment where they can provide those early testable drugs to patients anywhere with the right set of complex system biology. They need the relief to do that. And I think the FDA could work very easily on rapid approval. The environment at the FDA is there for that type of change. I think Rick Pastor has been nothing but cooperative. And we can't do it unless we begin to collaborate to aggregate enough patients in a given complex molecular system and test the regimens to get him the data he needs for approval. So that requires us rethinking everything. Intellectual property boundaries, proprietary business boundaries, the boundaries between academic medicine and community practice, the thinking about insurers, and the thinking about public funding. All of that has to be rethought, but with the ultimate goal and aim of, if we're going to completely change the way we think about cancer and its therapies, we have to have an infrastructure that supports it. And that's all you have to do in the next 2 years. Thanks.
Very good. Very good. Well, let's have a round of applause for our panel here. This was good.